Welcome to Raaonline. Today's topic is hirsutism. So what all pictures you are seeing on the screen, these are all ladies who have a problem for hirsutism. So excessive hair growth in women is to be discussed in today's lecture. The objectives of today's lecture is to define what is hirsutism and virilization in females, to learn about the androgen biosynthesis in females, to learn about the androgen types found in females, and to diagnose and treat hirsutism and virilization. So how do we define it? It is a terminal hair pattern in male distribution pattern and initially by the appearance of midline terminal hair. So this excessive terminal hair can be familial or pathological origin. The hair can be of three types. That can be vellus hair. Vellus hair is soft, downy and fine hair. Terminal hair is dark, coarse and kinkier hair, and lanugo hair is like the hair of a human fetus, which is found only in the intrauterine life. Now when a woman is exposed to androgens, first there will be terminal hair that will appear on the lower abdomen around the nipples, and next it will arise around the chin and the upper lip. Finally there will be hair between the breasts and the lower back, and usually a woman who is having hirsutism is also having an acne. So this is a pathophysiology of the clinical presentation. So how do we score hirsutism? We do it with the help of the Ferryman-Galloway scoring, in which various grades are given for the excessive hair growth on the lips, excessive hair growth on the chin, excessive hair growth on the armpits and the thighs, excessive hair growth on the chest wall, excessive hair growth on the midline, excessive hair growth in the pubic area, and excessive hair growth in the back and the midline in the gluteal region. Now what is virilization? Virilization is defined as masculinization, and it is associated with increasing testosterone levels as well as hirsutism. So in virilization, the first thing to happen is the enlargement of clitoris, then there is temporal balding, then there is a deepening of voice, then gradually the breast will involute, and then there can be a remodeling of limb shoulder girdle, and over time she takes a more masculine appearance. So this is a slow exposure over time to testosterone in a female. Now where does androgen come from? It can come from adrenal glands, it can come from ovaries, and it can also come from the peripheral adipose tissue, when it is called as the extraglandular production of testosterone from androstenedione in the peripheral fat component. Okay, so this slide is showing the secretion of LH and FSH from the pituitary. So if there is an increased GnRH pulse frequency, then it is more preferential to LH over FSH. So LH acts upon the theca cells which secrete androgen, FSH acts upon the granulosa cells which secrete estrogen. So if the pituitary is more preferential to LH, there will be more androgens than estrogens. Now there is another source of androgens which is coming from the adrenal gland. The adrenal androgens is the dehydroepiandrosterone sulfate. Another source of androgen is coming from the human adipose tissue, and this all is contributing to the increase in the androgen levels in the human body. Now how do the adrenal synthesize androgens? It is basically coming from the cholesterol. So in the presence of STAR, that is steroidogenic acute regulatory protein, and cholesterol side chain cleavage enzyme, which is desmolase or CYP17A, cholesterol gets converted to pregnenolone. Pregnenolone gets converted to progesterone by 3-beta hydroxylase dehydrogenase. Now this progesterone goes either into the mineralocorticoid pathway, the glucocorticoid pathway, or the sexsteroid pathway. The mineralocorticoid pathway is explained as pregnenolone to progesterone to 11-deoxycorticosterone to corticosterone and to aldosterone. Now CYP17 enzyme hyperfunctioning can deviate this pregnenolone to 17-hydroxypregnenolone, and which gets converted to 17-hydroxyprogesterone, which gets converted to 11-deoxycortisol, which gets converted to cortisol. This CYP17 also deviates this 17-hydroxypregnenolone to the sexsteroid pathway and forms a dehydroepiandrosterone, which gets converted to androstenedione and which is finally aromatized to estrone. Now inside the ovary there is a theca cell and there is a granulosa cell. So theca cell synthesizes testosterone from androstenedione, and granulosa cell secretes estradiol, which it synthesizes from the estrone. There is a two-cell, two-gonadotropin theory. So, the theca cell is acted upon by the LH, the granulosa cell is acted upon by the FSH. CYP19 aromatase enzyme converts androstenedione, which originates in the theca cell, and takes it to the granulosa cells. It goes to formation of the estradiol. Now, these testosterone, if they do not get aromatized properly and there is an arrest at this level, CYP19 aromatase enzyme deficiency in the ladies. So, if there is a block at this level, there will be more synthesis of androstenedione because of the backlogging of the precursor, and there will be increased testosterone in the female body if this CYP19 aromatase enzyme were not functioning properly. Now, this testosterone gets converted into biologically active dihydrotestosterone by 5-alpha reductase enzyme. Dihydrotestosterone binds to the androgen receptors and this causes the hair growth. Sometimes when we give a patient 5-alpha reductase inhibitors, so what will happen after this 5-alpha reductase inhibitor, her serum testosterone will be high, but her dihydrotestosterone levels will go down and her hirsutism will get responded. So, her hirsutism will regress. So, sometimes even if the testosterone levels are high, we can still get a response in the improvement of hirsutism by giving 5-alpha reductase inhibitors, because testosterone cannot cause hair growth as it is not the biologically active form. The biologically active form is only dihydrotestosterone.